Hello friends, today we are going to discuss about treatment-refractory OCD. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at NIMANS, Bangalore. Before I start my presentation, I would like to place this disclaimer. This presentation is for academic and training purpose only. For clinical opinion, please do contact a psychiatrist. Conflict of interest? None. In this video, I am going to discuss about the course and outcome of OCD, how to define treatment-resistant or else treatment-refractory OCD, what are the available strategies to manage treatment resistance, and conclusion. The target audience for this video is doctors, psychiatrists, neurosurgeon, neurologist, mental health professionals, mental health review board members, advocates, judicial officers, and persons with mental illness and family members. This video revolves around this important publication, that is Clinical Practice Guidelines on OCD, published in Indian Journal of Psychiatry in 2017. I was one of the member of this clinical practice guideline. Let's understand. OCD is a chronic waxing and waning neuropsychiatric disorder characterized by repeated thoughts and repeated acts, which are called as obsessions and compulsion. According to the World Health Organization, it is one of the most 10 disabling medical illness in the world. Not only that, if you look at the epidemiology, 1 to 3% of the population suffer from OCD in their lifetime. That means lifetime prevalence is 1 to 3%. If we extrapolated that data to India, it will be somewhere around 1.5 to 3.5 crore population suffering from OCD. Not only that, along with OCD, 2/3 of the OCD patients will have one more comorbid diagnosis. That means for every 4 patients, 3 patients will have one more psychiatric diagnosis along with OCD. Along with that, the quality of life, disability, dysfunction is almost similar to schizophrenia patient. OCD not only affects the person with mental illness who has OCD, it also affects the family members. Let's understand the treatment response in OCD. In the current scenario, SSRI and cognitive behavioral therapy are considered as the first line of treatment. However, in India, the availability of trained clinical psychologists to provide CBT are very few. Hence, the pharmacological treatment stands first in the line. Again, if you give medications, only 40 to 60% of the patient respond to first SSRI. Hence, sequential trial of SSRI has to be tried. In reality, let's understand what is the course and outcome of OCD patients in India. In NIMANS OCD clinic, there are studies done regarding the course and outcome of OCD patient. I'll be presenting only few of them. One of the landmark study, that is follow-up of OCD patient over 11 to 13 years. A study was done. And in this study, when the patient were seen after 11 years, we found that 43% of our patients recovered completely. 33% recovered partially, who required medication and support, but they were able to function on their own. But however, 24% did not recover. They require complete support from the family. One more study, which is a 5-year follow-up study, in that when we looked at predominantly obsessive patients, that means who do not have compulsions but only obsessions. After 5-year follow-up, we found that 42% recovered completely, 36% recovered partially, they required medication, they required therapy, they required some amount of assistance from the family, but they were able to live independently. But they had symptoms. 22% did not recover at all. And a 5-year follow-up of mixed obsessive-compulsive disorder patients. The patients who had both obsession and compulsions. After 5-year follow-up, we found that 33% recovered completely, 34% recovered partially, and 33% did not recover at all. To summarize the follow-up studies from Niemann's OCD clinic. It clearly understands that 25 to 30% of our OCD patients do not respond either to medication, therapy, or augmentation strategy. These 25 to 30% patients are severely disabled. They require support from the family. Their quality of life is poor. It not only affects the patient but also the family members. That means we need to look for newer strategies of treatment. There is still hope. There are certain experimental treatment approaches are available. They are called as novel approach. There are something called as deep brain stimulation and neurosurgical approach. If you weigh the risk of side effects because of the surgery or novel approach treatment versus disability because of OCD, that means the disability because of OCD is very severe. Whereas the side effect of this neurosurgery, brain stimulation, and novel approach can be manageable. That means there is a hope. Let's understand what are the predictors of non-response to treatment. Again, I am presenting the data across the world and also from India. If there is a comorbid, other illnesses such as tic disorder, drug abuse, alcohol abuse, personality disorders, they do not respond to treatment. If the patient has poor insight to OCD, he usually does not respond. Early onset OCD or juvenile onset OCD also do not respond to treatment. Certain obsessions like sexual obsessions, hoarding, symmetry, and also schizotypal symptoms are there. They do not respond to treatment. Certain compulsions like washing and miscellaneous compulsions may not respond to treatment. Lifetime access disorder like major depression and at the same time baseline severe OCD, personality disorders play a very important crucial role in not responding to treatment. Longer the duration of illness, poor adherence to homework assignment for therapy are those people who do not respond to treatment. So these are the predictors of non-response to treatment. Let's define what is treatment-resistant OCD. When do we call it the patient is not responding to medication or therapy? There are various definitions are available. They are inconsistent and defining treatment response is very difficult. This has plagued the researchers since many years. There are various terms have been used. Non-responder for medication, non-responder for SSRI, treatment-resistant, treatment-refractory. Along with this, even treatment response is not uniformly defined. This is a big challenge to understand what is treatment resistance, what is treatment refractory. There is not a uniform definition which is accepted across the world. However, there are some commonality in definitions to define treatment resistance. First and the foremost is severity rating scale like YBOX or else CGI and S. These are the rating scales which have been used to say the person is not responding to treatment. Number of medications tried, that is adequate dosage and duration. If they do not respond for 2 medicines or 3 medicine, based upon that also the treatment response or non-response is defined. At the same time, number of CBT sessions, durations, response, relapse, number of attempts of CBT done also have been used for the definition of treatment resistance. Similarly, the definition of response or non-responsiveness is considered as not 100%. If the patient do not respond even 35% on YBOX scale is considered as treatment resistant. Even if they don't respond even 25% on YBOX scale is also considered as treatment resistance. And even if the patient has YBOX score more than 16, that means he has not improved at all. Further, CGI also has been used, that is clinical global improvement. There, if the score is 3 or more, that means he is non-responsive. That means there are various definitions have been used by researchers. At the same time, as I mentioned, number of serotonin reuptake inhibitors. On that basis also non-response has been defined. If the patient does not respond to one medication, it is also called as a non-responder. If the patient does not respond to SSRI, that is also called as a non-responder. If the patient does not respond, which is commonly used earlier, was 2 SSRIs, 1 clomipramine, and cognitive behavioral therapy, is the commonly accepted treatment-resistant definition. At the same time, there is one more term, treatment-refractory. How resistant is different from refractory? Refractory of OCD is defined as failure to respond all available approved treatment is considered as refractory. But however, some researchers also said that refractory OCD is defined as failure to respond for 2 adequate trial of SSRIs. That is also considered. But the issue of, again, it becomes complicated because now there are augmenting agents. If there are how the augmenting agents are used, and if they do not respond, whether they should be considered for definition or not is not clear. But however, for this presentation, I'll be using refractory OCD as this definition. The definition of refractory OCD means at least the patient has been tried with the 2 SSRIs with adequate dosage and duration, 1 clomipramine, that is the third medication, with adequate dosage and duration, 2 augmenting agents for at least 2 months, along with 1 attempt of CBT for 20 sessions. Is very essential to call it as treatment non-response, and the patient should have 3 years of continuous illness and Y-box score of more than 28. Will be considered as refractory OCD who requires novel approach for treatment. However, this is the definition used for various research nowadays. That means if the patient meets this criteria, at least 2 of them, then we can consider it as refractory OCD. However, this is the definition which I found which is very appealing. But however, depending upon the clinical scenario, depending upon various available treatment methodology, this definition can be altered. But for this presentation, 2 SSRIs, 1 clomipramine, 2 augmenting agent, and 1 cognitive behavioral therapy lasting for 20 sessions, if he does not improve and he had 3 years of continuous illness, and if he has more than 28 Y-box score, that means he can be easily considered as treatment refractory who requires novel approach for treatment. Let's understand how to approach for treatment resistance or refractory cases. Treatment non-responsiveness is a challenge to any psychiatrist, especially with OCD. What are the steps we should take? First and the foremost step is reassessment of OCD patient. Why this is required? To know whether the patient has a pseudo resistance, whether there is a comorbidity, whether there is a personality disorder which is coming in the way of response, or else is a true resistance. That means medication has not improved. The second step would be check for comorbidity. And if there is comorbidity, treat that comorbidity. As you see, 2/3 of the patient, that is around 60 to 70% of OCD patients have one more psychiatric diagnosis, such as depression, 60%, panic disorder, 25%, social phobia, generalized anxiety disorder, eating disorder, bipolar disorder. So various axis 1 disorders will be there. You need to identify them and treat them. Then only we will come to know, yes, the patient is responding or not. Further, if the patient has personality disorder, then also the patient may not respond because we need to address personality disorder also. 40 to 50% of the OCD patient has personality disorders, and they may become a challenge either for medication or else for cognitive behavioral therapy. The third step, check for pseudo resistance. That means the patient is not taking the medication in the right dosage, or else the patient has not taken for adequate duration, not adhering to the treatment regimen, not doing homework assignment in cognitive behavioral therapy. In such a scenario, you have to do supervised medication. If you are not sure the patient is not taking medication, it is worthwhile trying the medication again. Please remember, there are various research clearly said 1 in 4 patient, that is 25 to 30% of the patient, when the medication is started, they do not take the medication. That means 30% of the patient have at least pseudo resistance. You have to keep this in mind. Hence, Supervised medication is very, very essential in OCD. If the true resistance is confirmed, because there is a supervised medication, adequate dosage has been given, adequate duration has been given, but the true resistance has been proved. In such a scenario, we have 5 important strategies. One is augmentation, switching, combination therapy, mega dosage therapy, and novel approach, that is psychosurgery. We will discuss all 5 of them. They are very important with regard to treatment resistance or refractory OCD. Let's understand about augmentation strategy. Augmenting agent are those agents which given alone will not have any effect on OCD. It has to be combined along with an SRI. That means here the patient need to be on SSRI, and if he has shown partial response, then an augmenting agent has to be given. Predominantly when we are giving SSRIs, and then if there is a partial response, first line of treatment will be augmenting agent, that is antipsychotics. The antipsychotics have been also blamed for triggering OCD symptoms. But however, series of literature and also research clearly said that the benefit of giving antipsychotics outweigh the risk of precipitating OCD in antipsychotics. That means clearly risperidone has been found to have a beneficial effect in augmenting agent. Hence, antipsychotics can be used as an augmenting agent if there is a partial response with SSRIs. However, there is a few literature which says that antipsychotic can trigger OCD symptoms. If you find that antipsychotic triggers OCD symptoms, do not give antipsychotics. But however, risperidone, quetiapine, olanzapine, haloperidol, these are the drugs have been tried as an augmenting agent. If you feel that antipsychotic is triggering OCD symptoms, you can try other augmenting agent like memantine, glycine, ondansetron and granisetron, gabapentin. These are the medication which can also be tried as an augmenting agent. Further, the other research molecule which have been tried in augmenting agent is riluzole, which is very costly, topiramate, memantine, pindolol, oral morphine. So these are the augmenting agent which can be tried. The augmenting agent should be tried at least 6 to 8 weeks, that is 2 months. If the patient responds on augmenting agent, you need to continue. You cannot stop. That means you'll be giving an SSRI along with an augmenting agent. If there is no response at all, that means you are not going to do augmentation, you will do a switching strategy. That means you will switch from one SRI to another SSRI or else another SNRI. So switching is allowed only when there is no response at all. That means if there is no improvement of less than 35% on Wybox scale, then switching should be the strategy to be allowed. So switching is from one class of drug to another class or within the same class can be tried. Here, if the class within class is from one SSRI to another SSRI, if the patient do not respond to fluoxetine, try sertraline. The next one is if the patient do not respond to SSRI, the patient can be switched over to clomipramine. The switching should be done very carefully. That is, cross tapering has to be done. The next one, if the patient do not respond to SSRI, you can try SNRI, that is venlafaxine or desvenlafaxine. Sometimes you can also consider NASA, that is mirtazapine. That means if the SSRI is not responding, you can try mirtazapine, that is switching over can be tried. If the patient does not respond to either augmenting or switching over to another drug, it does not respond. Now is the time for combination strategy. That is combining one SSRI with a low dose clomipramine. The low dose means it may be less than 150 mg or else 100 mg. Escitalopram with clomipramine or else citalopram with clomipramine, fluoxamine with clomipramine. Whenever you are doing this combination strategy, please watch for serotonergic syndrome. That is very essential because combination of two SSRI can precipitate side effects. Further, you can also combine clomipramine in full dosage along with an SSRI, like clomipramine with escitalopram. That means here clomipramine will be in the full dosage, escitalopram can be in low dosage, or else fluoxamine. The next one is full dose combination. That is, you will give sertraline in the dosage of 200 to 300 mg, clomipramine at the dosage of 225 to 300 mg. That means here you will be giving both the medication in full dosage. The commonest is clomipramine and fluoxamine. Here clomipramine you will be giving up to 150 to 225 mg and fluoxamine up to 300 mg. This is when you are giving full dosage of combination, you have to be very careful and look for serotonergic syndrome. So this is a very essential step. Now, if the patient does not improve even with combination strategy, then mega dose strategies have been applied. Here, the patients have been given higher dosage, such as sertraline is given up to 400 mg sometimes, or else fluoxetine given up to 120 mg, escitalopram given up to 60 mg. So these are all in a research mode. However, certain few studies, such as open label trial, has found to be beneficial. But however, before you do mega dosage strategy, please explain the patient. Tell that I'm trying higher dosage and explain about the side effect. These are only minority of the patient may benefit with higher dosage of medication. And you have to weigh benefit versus risk of side effect. That needs to be kept in mind, and this need to be explained to the patient. However, mega dosage therapy can be tried only in a tertiary centers like medical college or else the mental hospitals such as NIMANS, All India Institute of Medical Science, PGI Chandigarh, CIP Ranchi. These are the places where these mega dosage to be tried, and it should be tried only when the patient is not responding to treatment. Further, the studies have clearly said that high dose of escitalopram, high dose of sertraline, high dose of fluoxetine, in certain few subset of patient it shows improvement. Hence, it is worthwhile trying high dosage of medication, but with the consent of the patient. Now, there are certain strategies have been also used, like combining cognitive behavioral therapy with medications. This is one of the strategies been adopted extensively in India because accessibility and availability of cognitive behavioral therapy is very few and it is available in few centers. Hence, behavioral therapy, although has been advocated as a first line of treatment in Western literature, in India, access, availability is a big challenge in cognitive behavioral therapy. However, cognitive behavioral therapy not only can be used as a first line of treatment, it can be an augmenting agent with medication, or else if the patient is not responding to medication at all, then adding cognitive behavioral therapy is very essential. Hence, studies have also shown that behavioral therapy alone or with SSRI combination can reduce frequent relapse in OCD patients. However, expert consensus guidelines clearly said that combining SSRI along with CBT to be done when there is no treatment response. And again, CBT should also be used as a first line of treatment in certain set of individuals, especially in young children, if a patient is pregnant, if the patient has bipolar disorder, if the patient has personality disorder, if the patient requires augmentation for an ongoing SSRI, then cognitive behavioral therapy can be used. Also, cognitive therapy can be given as a standalone, can be given as augmenting agent, or else can be added along with other medications, or also to be added along with novel approach treatment such as neurosurgery. Let's understand. CBT, if it is added with SSRI, what is the treatment response? There are important studies, well-controlled RCTs have been done. One of the study I am mentioning here. In this study, there was a comparison of RCT with clomipramine versus CBT versus combination of medication and therapy. The results speaks itself. The combination of ERP and clomipramine showed 39% improvement, especially with regard to treatment-resistant OCD. Hence, it would be worthwhile combining medication and therapy. Moving to further, expert consensus panel recommends CBT for those who do not respond to SSRI. Do we have any studies which says if the patient does not respond to medication, will he respond to therapy? There are hardly few studies. Some of the studies have clearly said that even if they do not respond to SSRI, CBT can be tried and it has been useful. This is one of the study which was done in Nieman's OCD clinic. I am one of the author of this study. This is a well-conducted study by Dr. Nitin. This study was his PhD thesis. In this study, it clearly found that 48% to 60% found remitters and responders. That means if the patient is not responding to medication, if you add CBT along with medication, that means you are not going to stop the medication. Along with the medication, if the cognitive behavioral therapy has been applied and it was followed up after for 1 year, they found 48% completely remitted and responder were 61%. That means 40 to 60% response is there with therapy. Further, if the patient does not respond here also, one more important study has been done. That is intensive residential cognitive behavioral therapy. That means the patient will be admitted in a hospital or else in a rehabilitation center, and on daily basis cognitive behavioral therapy is done. That is 60 to 90 minutes therapy is done by an assisted therapist, which will last for more than 90 to 120 days. That means the patient may require around 50 to 60 sessions of OCD. That is called as intensive residential cognitive behavioral therapy. There are two British studies. One is Drummond et al. 1993 and Buchanan et al. 1996. In both the studies, it said that intensive residential therapy showed 40% improvement. Even in American study, that is by Stewart et al., which is again I would consider as a landmark study because of the huge number. Here also, it clearly said that 40 to 50% showed improvement in this study. And again, here the treatment lasted for more than 3 months. Total response was around 59%. That means again, it is more than reduction of iBox 25%. It is not 100%. So, there is a scope for intensive residential therapy in India. Hence, there was a study conducted by Nieman's. It was a follow-up study and it was done in Nieman's. And in this study also, they found that remitters were 14% and responders were 36%. That means few patients of OCD will require rehabilitation, and in rehabilitation, intensive cognitive behavioral therapy. The therapy may last from 30 sessions to 60 sessions. Here, some of the patient may not even respond to CBT also. So this is one of the area which can be considered. Now, there is one another novel approach for treatment has been known. That is medication facilitated cognitive behavioral therapy. One of the commonest used is clonazepam. If the patient is very anxious and is not able to expose himself to the anxiety-provoking situation, that is ERP, if he is unable to do, the clonazepam can be given, buspirone can be given. So these are all medication-facilitated cognitive behavioral therapy. One of the other well-known study is D-cycloserine. Here, this helps in extinction of fear that has been studied. And there are 2 or 3 studies in open label have been found that D-cycloserine is helpful in habituation. But however, there is no well-controlled studies to say D-cycloserine should be given during CBT so that the habituation occurs, the patient is able to expose himself and do ERP scheduling. Now moving to the important aspect, that is novel strategy. Novel strategy is nothing but brain stimulation therapies. Brain stimulation therapies are also called as neuromodulation, somatic therapies, and psychiatric neurotherapeutics. Again, if you take all the brain stimulation therapies, there are 2 important. One is non-invasive, another one is invasive. Non-invasive, that means you are not doing any operation on the patient. That is basically brain operation. Invasive, that means you will be doing operation. That is neurosurgery. Now let's discuss non-invasive and invasive. If you come to non-invasive, electroconvulsive therapy has been tried. Again, it has been clearly said in various studies, electroconvulsive therapy in OCD is not useful at all. It is very limited useful. But however, ECT has been given in OCD patient if the patient had comorbid severe depression If you had comorbid bipolar disorder, if the patient is very suicidal, aggressive, that means ECT can be tried for comorbid condition. As I earlier told, at least 60 to 70% of OCD patients to have another comorbid condition. To treat comorbid condition, ECT is very helpful. But however, ECT as a first line of treatment or else a standalone treatment for OCD is not been approved in any of the guidelines. Now ECT has been ruled out. That means ECT can be given for comorbid condition. Now, similar to ECT, ECT is an alternative current. There is one more strategy has been tried. Transcranial direct current stimulation. It is called as Tdcs, which has been tried. Here, the patient will be given a current of 1 to 2 milliampere and two electrodes are placed on certain specific points on the brain and the mild electric current is given. Even if you apply this Tdcs, it will be a tingling sensation which will be felt on the patient. It is not an alternative current which is given in higher dosage. Here, it is a mild current given as a transcranial direct current stimulation. Again, if you look at various studies about the review of Tdcs, and there are meta-analyses have been done. And in the meta-analysis, it has been clearly said that despite of methodological limitation, heterogeneity of stimulation parameters, dosage, placement of electrical electrodes, and also the type of patient who are being chosen, whether they are on medication, number of medication tried, whether they are on cognitive behavioral therapy, Tdcs has been found to be promising in nature. And the studies have clearly said that Tdcs can be useful in certain subset of patient. Hence, transcranial direct current stimulation is one of the strategy. But however, the research is needed, especially randomized control trial has to be done. Again, there is one of the study which has been done in Niemann's OCD clinic on Tdcs. This was published recently in 2019. In this study also, they clearly said that Tdcs is very helpful in SSRI resistant OCD. That means if the patient has not responded to SSRI, Tdcs can be tried. That means this is one of the other promising area which can be tried. After moving from ECT and transcranial direct current stimulation, let's move into transcranial magnetic stimulation. In the earlier one, directly the electric current is given. Here, by using magnetic field, we are inducing electrical current in the neurons. Here, the patient, as you see in the figure, you will find the electrode, that is, magnets are placed on certain areas of the brain. And by passing alternative electrical current, magnetic fields are produced. Again, when this magnetic field is applied perpendicularly to the neurons, so mild electrical currents are generated in the neurons. And transcranial magnetic stimulation has been found to be very useful in moderate depression, and it has been approved in the treatment of depression. Hence, transcranial magnetic stimulation has been tried even in OCD. Various randomized control trial has been done, and it has been found to be very useful because of it is easy to use, it is non-invasive, does not require any anesthesia, side effects are very minimal, sessions done almost all daily basis over a period of 20 to 30 sessions. Hence, it is called as repetitive transcranial magnetic stimulation. So, these studies have found that it is useful. But however, the studies also said that it is difficult to compare between studies. The reason being is the placement of electrode, that is, the placement of magnets, varies from studies to study. Stimulation parameter, frequency, contaminating the subjects with various other medications, presence or absence of comorbidity, duration of follow-up finds it very difficult to compare this study. However, repetitive transcranial magnetic stimulation, in certain studies it has been found to be useful. But however, it has to be given a session from 20 to 30 sessions. And depending upon where you are going to stimulate plays a very crucial role. The promising area has been found to be bilateral dorsolateral prefrontal cortex has been found to be more favorable for rTMS. I'll repeat, bilateral dorsolateral prefrontal cortex has been found to be favorable, and it has been found to see that when the rTMS is given, there is a brief improvement seen over a period of 2 to 3 weeks. But again, it has to be given with SSRI. rTMS cannot be given as a standalone treatment because the evidences are very few. Hence, it is advisable to continue medications and apply rTMS as an augmenting agent. Now, various other areas have been tried, such as once I said one is lateral prefrontal cortex is very promising area. The other areas which have been found to be useful in supplementary motor area, orbitofrontal cortex, medial prefrontal cortex, and anterior cingulate cortex. However, rTMS has been found to be useful to some extent, but however, deep transcranial magnetic stimulation has been found to be very helpful, and the early literature says it is very, very promising. And here, again, the studies clearly said that, again, it is a meta-analysis and a review which clearly said that OCD patients benefited from deep transcranial magnetic stimulation with high frequency stimulation and or else intermittent theta burst stimulation protocol or combination of high frequency and intermittent theta burst stimulation along with using H7 coil. That has been found to be very helpful. There are preliminary studies which says that deep transcranial magnetic stimulation combining with SSRI medication can be used as an augmenting agent. In few open label trial, a standalone treatment can also be done. But however, the improvement starts at the 20 session of transcranial magnetic stimulation. And the session should be continued up to 30 to 35 sessions. That means every week, at least 5 sessions will be given. Some of the studies have said 2 sessions can be given in a day. But however, across the world, 1 session per day has been done. Depending upon the protocol, depending upon the availability, depending upon whether the side effect is there or not, we can try twice a day or once a day stimulation. But the session should be up to 30 sessions. With all this stimulation, now we will enter into invasive procedure. That means the patient requires surgery. That means ablation. That means you are making certain small lesions in the brain. That means you are cutting certain parts of the brain or else doing surgery on the brain. So these are called as invasive procedures. If you look at the psychosurgery, that is neurosurgery, but unfortunately it is a old term. It is neurosurgery for OCD patient. This should be used as a last sort of intervention. It cannot be used as a first line of treatment because psychosurgery is still in research process. And if the patient has a refractory OCD, it is debilitating, he is completely disabled, and it is affecting the whole family, then only psychosurgery should be considered. There are 3 different types which has been available now. One is stereotactic surgery, where the borehole is made and the surgery is done. The second one is gamma knife surgery, where gamma is focused on a particular point and radiation is done by burning that area. Third one is deep brain stimulation. So we will discuss all of them. But however, before you enter into psychosurgery, as per Mental Health Care Act of 2017, Section 96 clearly says Mental Health Review Board permission has to be taken before you do surgery. Let's understand what is the importance of neurosurgery in OCD. Everything revolves around choosing the patient. You have to choose an appropriate patient who is treatment resistant, who is completely refractory for all available approved treatment. You have to take informed consent from the patient. That is very essential. Mental Health Review Board permission has to be taken, and the patient should know it is in experimental stages only. It is not well approved well-known, well-researched area. It is now the studies on psychosurgery on OCD has been started. But you should also know there are certain contraindications. The contraindication for psychosurgery is psychosis. If the patient has OCD with comorbid psychosis, if the patient has comorbid bipolar disorder, patient has intellectual disability, autism, or else any other comorbidity, severe personality disorder, if the patient has medical comorbidity or a medical condition which does not allow him to put him to surgery, or a severe neurological condition like intractable epilepsy, or else surgical illness which gives him contraindication for any kind of anesthesia. In such a scenario, you cannot put the patient under neurosurgery. But however, we should know once the patient you have chosen properly, you have to do a pre-surgical workup. That means before you subject a patient to surgery, these are the important steps you should take. You have to do OCD assessment thoroughly by a structured instrument, along with comorbid condition needs to be assessed and to be addressed before in hand. And you have to assess for treatment resistant thoroughly, for medications, cognitive behavioral therapy, and for augmenting agent. Before the surgery is done, neuropsych assessment has to be done along with personality assessment, because you are doing ablation in certain areas of the brain. Patient may develop cognitive deficits after surgery or else personality changes. Hence, baseline assessment of cognitive function, baseline assessment of personality assessment to be done. And you have to take opinion from neurology, neurosurgery, and radiology, because majority of this neurosurgery, a multidisciplinary team has to be done. Further, you have to do MRI after fixing the stereotactic frame. Then only you will be able to know the localizing, the distance, placement of electrode, or else where the ablation has to be done. And one important step you should never forget is informed consent. In the informed consent for neurosurgery, it has to be by the patient. One, and the patient and the family member should know what is the expected outcome. All neurosurgery cases for OCD, the studies at which are available says only 40 to 60% improvement occurs. That means it is not 100%. That is one. The improvement occurs over a period of 6 to 12 months. That means if the patient undergoes neurosurgery today for OCD, the improvement will be seen only after 6 to 12 months down the line, not immediately. That means latency in response is seen. The patient should understand there are side effects, sometimes life-threatening. Hence, still we call it as it is under a research mode. Medications to be continued. That is very essential. You cannot stop SSRI or cognitive behavioral therapy telling that surgery has been done. So once the surgery is done, the patient should continue medications. Patient should continue cognitive behavioral therapy. Sometimes if the patient has undergone neurosurgery, patient may require anti-epileptic prophylaxis. He may require steroids to decrease the edema. Hence, some more medication will be added by doing psychosurgery. Majority of the OCD patients feel that if they do psychosurgery, medications cannot be taken. No, this is completely a myth. Even if the patient has undergone psychosurgery or neurosurgery, medication and therapy should be continued. And the patient should also understand it is still in experimental mode. And very essential is follow-up monitoring for neurosurgery has to be done to know, because of the lesion, what we have done because of neurosurgery, whether the patient has developed any neurological deficit to be monitored. Now let's understand what are the areas of the brain which are very interested for ablation or else target areas in the brain. So psychosurgery procedures which are considered beneficial are cingulotomy, capsulotomy, and limbic leucotomy, and subchordate tractotomy. Let's discuss all of them. Anterior cingulotomy, which is commonly used across the world. Here, the lesion is placed bilaterally on anterior cingulate gyrus. So this is one of the commonest one. Next one is anterior capsulotomy. Here, ventral part of the anterior limb of the internal capsule, the lesion is placed. This is again one of the commonest surgery is done. So anterior cingulotomy and anterior capsulotomy is used very often. However, subchordate tractotomy has also been used. Here the lesion is placed in the substantia innominata. So here the lesion is placed. Moving to the limbic leucotomy. Limbic leucotomy is a combination of cingulotomy and tractotomy. However, the first two, anterior cingulotomy, anterior capsulotomy, are the commonest used psychosurgeries. However, there are no studies to compare between all these four procedures, which is best, which is having maximum side effect. There are no head-to-head comparisons. Along with this neurosurgery, there is a new thing has come, gamma knife surgery. This is non-invasive in nature, but however, you are going to place an ablation, or else you are going to give certain tracts will be cut using radiation. This is non-invasive, highly patient acceptance. It is 1 or 2 settings in the gamma radiation machine. Here sham surgeries can be done. The need for follow-up is very low, and there is no burr hole is done in the brain. So here, this is how. Here cobalt-60 radiation is given from all 360 degree in a particular area where you want to cause the lesion. Once the radiation is done over a period of time, then that area, that tract will be burnt by the radiation. Hence, it is non-invasive, but it cannot be reversed. Here, the lesion will seen only after 3 to 6 months under CT scan. That is about gamma knife surgery. But however, there is another surgery which is done, stereotactic surgery, that is thermocoagulation by using radiofrequency or cautery. Here, the patient will undergo a small surgery. A burr hole is placed on bilateral part of the skull, and then the electrodes are placed in a particular area, and then the thermocoagulation is done by either radiofrequency or cautery. There are various studies have been done. This is better than the lobotomy. Here again, cingulotomy is the commonest, anterior cingulotomy is the commonest stereostatic surgery has been done. It is very cheap, and again, cheap means it is very economical. And again, the side effect profile is also very less, such as epilepsy is maybe 1 to 2%, personality change is around 7%, suicide in 1% of the patient, cognitive disturbance is 5%, death is very rare, and very few. Stroke also has been seen. Overall, acceptance, accessibility, and stereotactic surgery is found to be very useful in Indian population. Further, follow-up of all these psychosurgeries or neurosurgeries in OCD have clearly said that improvement is around 40 to 60%. That means only 50% of neurosurgery patient in OCD will improve. And again, the treatment response will be seen only after 6 to 12 months after the surgery. But however, one need to know post-neurosurgery OCD care is very essential. And you have to remember, neurosurgery will not be a standalone treatment. It has to be combined with medication and CBT. Response is delayed after 6 to 12 months. Medication and CBT be continued. I am stressing this point because many of our doctors, many of our OCD patients believe if a surgery is done, no need to take medication. That is completely wrong. Some of the patients require steroid, anti-epileptic prophylaxis. That is simple reason is once you place a lesion in the brain from outside, either by surgery or by gamma knife, that lesion can become a foci for epileptogenesis. Hence, some patients may require anti-epileptic prophylaxis. We will discuss about deep brain stimulation. Deep brain stimulation is a novel technique which has arrived recently. It has been successfully used in Parkinson's disease and various other movement disorder. Here, electrical stimulation is done by implanted electrode through a pacemaker. This is again non-ablative. Here, you are not going to make any lesion, but you are going to do a surgery and you place the electrodes in the brain. It is adjustable. RCT can be done. There are now research pouring with regard to deep brain stimulation. The deep brain stimulation has been approved in US by FDA for Parkinson's disease, dystonia, tremors, and in February 2009, it has been approved for obsessive-compulsive disorder also. Here again, for DBS, deep brain stimulation, the steps are there. I will discuss this in 8 steps. However, deep brain stimulation has been discussed in various literature in 3 stages, but I am discussing in 8 steps because it is easy to understand. First step is choose the patient appropriately. That means the patient should be refractory. Patient understand what is deep brain stimulation. The patient knows the improvement is around 50 to 60%. At the same time, improvement occurs over a period of 6 to 12 months. At the same time, it is costly. Along with that, baseline assessment has to be done of OCD and comorbidity. Legal approval under Mental Health Care Act of Section 96 has to be done. Although we call it as non-ablative, but you are doing a burr hole. That means you are placing the electrodes in the brain. Hence, it is a neurosurgery. Hence, there is a requirement from Mental Health Care Act of Section 96. The approval has to be taken from the Mental Health Review Board. Once this has been done, you have to do baseline neuropsych assessment also. After that, you have to go for MRI. That means the patient need to attach a stereotactic frame on the skull. Once that is placed, neuroimaging, that is MRI, has to be done. Once the MRI along with the stereotactic frame is done, you have to calculate the distance and focus where you are going to stimulate. After that, the neurosurgery is done by making 2 burr holes. When this surgery is done, it is done under local anesthesia by giving mild sedation. In DBS, the patient will be awake. The main reason is when the electrode is placed, and the patient should be able to speak so that we can assess the patient when in the OT only. So that if the patient has any problem in speech, any problem in cognitive functioning, that can be a indication that your placement is wrong. Hence, patient will be awake. Patient will be asked to do certain tasks, certain like moving his fingers. At the same time, some mild stimulation will be given so that the patient response will be calibrated on the OT table. Once it is done, the placement is placed, the electrode placement is done, and the patient will be discharged. After a few days, a second operation is done to place the pulse stimulator or else a pulse generator in the subclavian fossa. Here, the generator is placed, which is usually done in general anesthesia. Once the placement is done and the electrodes are connected to the pulse generator, the patient will be discharged and he will be called for programming the stimulator. Here in programming the stimulator is a very essential step in OCD. Especially in movement disorder like Parkinsonism, tremors, and dystonia. As you do the stimulation, you can see the decline in tremors, decline in Parkinsonism symptoms, whereas in OCD it doesn't occur. If you stimulate, the OCD symptoms do not disappear immediately. You have to wait for 1 to 2 months to symptom to resolve. If the patient does not respond, then you have to increase the dosage of stimulation. That means the programming has to be done frequently. And it is you are placing a device inside the brain and also a pulse generator in the subclavian fossa. That means it has to be monitored very closely. Let's understand how here we do the placement. Here is the surgery, a burr hole is done and electrodes are placed in certain area to stimulate. And this is how in the subclavian fossa, the pulse generator is placed. This pulse generator will be used to generate electrical impulses and then which will be stimulated through the electrodes. Now let's understand all the process one by one. Here the patient is you can see that the electrode is placed, and from the pulse generator, the impulses go through the wire and stimulates the electrodes, and the area of interest will be stimulated. This is how it looks once the implantable pulse generator is placed and the electrodes are placed and the pulse generation is given, and depending upon the stimulus and response over a period of time, the dosage is calculated. In OCD, it takes time. Please remember that, because OCD symptoms do not disappear immediately the way it happens in Parkinsonism. And what are the target areas which have been found to be useful in deep brain stimulation? The commonest is anterior limb of internal capsule, ventral striatum, subthalamic nuclei, nucleus accumbens, head of the caudate nucleus, medial dorsal nucleus of the thalamus, inferior thalamic peduncle. But however, anterior limb of the internal capsule has been found to be favorable for many researchers. Let's understand. Deep brain stimulation has both advantages and disadvantages. Advantages: DBS has found to be very effective. There is no lesions made in the brain. That means it is reversible. Side effects are there, but there are very few. Stimulation is adjustable. Sham stimulation to be done so that RCT can be done easily in this DBS. And stimulation parameters can change. At the same time, you need to know the improvement occurs over a period of time, and whenever the stimulus parameters is changed, you need to wait for the response. However, the disadvantage is the cost. The cost of DBS is around 8 to 15 lakhs. And periodically, the battery's replacement has to be done, the pulse generator. And there is a requirement of highly skilled interdisciplinary team is required. Frequent monitoring and also programming of the pulse generator has to be done very efficiently. There are some side effects like intracerebral hemorrhage, infection, and seizures are known to occur. There are studies which have done the review of DBS. It has been found to be helpful up to 50 to 60% in DBS patients. And recently, one of the study also said that deep brain stimulation is very effective in treatment-resistant OCD. But let's decide which treatment has to be chosen. Whether it should be stereotactic surgery, or else it should be gamma knife, or else deep brain stimulation. So everything, which one to choose depending upon the access for those treatment. Whether if a person is able to access multidisciplinary team which consists of psychiatrist, neurology, neurosurgery, and neuroradiologist, and the pulse generator monitoring is possible, then DBS will be effective. But again, you should remember, the cost plays a very essential role in India. If there are contraindications for surgery, then gamma knife will be the best, because you are not doing any surgery here. It is only through radiation you are going to cut certain part of the neuronal tracts. But again, the important will be access for post-operative care. That means if you are doing DBS, deep brain stimulation, the patient need to go and meet the neurosurgeon and neurologist very frequently along with the psychiatrist. That means every month the follow-up is required. The patient should be very careful because there is a possibility of intracerebral hemorrhage. Patient should be waiting for the response to occur. That means DBS, although is found to be very effective, but it is a very tedious procedure. Hence, the choice would be either stereotactic surgery will be chosen if the money is very less. If there is a contraindication for surgery, gamma knife will be better. And if the patient says, I don't want any ablation in the brain, then DBS will be the commonest choice. If you look at the cost-wise, stereotactic surgery is very cost-effective. Within less than 1 to 2 lakhs, stereotactic surgery can be done. In a tertiary centers like NIMANS, All India Institute of Medical Sciences, this stereotactic surgery costs very less. Gamma knife, again, the cost will be around 2 to 3 lakhs. There are many centers in India, gamma knife is available. And further, DBS, the cost will be 8 to 16 lakhs. And again, if every 5 years battery has to be replaced, If there is a malfunctioning of pulse generator, that means it has to be replaced. The cost may escalate also. So depending upon the affordability, access to multidisciplinary team, and also if there is any contraindication for surgery, based upon either of this surgery can be planned. But however, there is inherent challenges of all this novel treatment. Please remember, OCD is a heterogeneous condition. Different neural circuits are involved in the OCD. Hence, which circuits should be targeted for stimulation or for ablation or cutting those tracts has to be done very intelligently. There are benefits, but at the same time risks are also available. But please remember, neurosurgery OCD is still in experimental treatment. It is not approved across the world. Some centers place high research protocols, permission through the law, informed consent is mandatory. A recently OCD clinic NIMANS consultants have published a study that was published in 2019. The title of the study is Ability Neurosurgery and Deep Brain Stimulation for OCD. This is one of the wonderful articles. You can go through that to know which neurosurgery to be chosen, what are the side effects. That is given very beautifully in this article. To conclude, my dear friends, the first line of treatment still SSRI and cognitive behavioral therapy. Augmentation with atypical antipsychotics has been well approved across the world, although only few studies talks about antipsychotics provoking OC symptoms. But remember, adding CBT along with SSRI is found to be very beneficial. Sometimes CBT can be used as a standalone, can be added as an augmenting agent, or else along with the medication CBT can be given. Most of the patient requires long-term treatment. Surgery is highly effective, should be tried only in refractory cases and severely ill patients. But however, before you do psychosurgery, intensive inpatient cognitive behavioral therapy has to be tried. That is, intensive residential behavioral therapy to be tried. Sometimes, some of the researchers and clinicians do try mega dosage and combination treatment. Some few patients do benefit by this treatment. But however, before subjecting for any person on psychosurgery, Mental Health Care Act of 2017 mandates under Section 96 for approval from Mental Health Review Board. So coming to psychosurgery, it is the affordability, side effect profile, access to multidisciplinary team will decide whether it should be stereotactic surgery, gamma-knife surgery, or deep brain stimulation. To conclude, as a take-home message, whenever there is a treatment resistance or refractory, do reassessment, confirm whether there is a true resistance, try augmentation strategy, try switching strategy, try to do combination strategy. After taking consent, do mega dosage approval or treatment, and finally, novel approach of psychosurgery. That is, neurosurgery OCD should be the last resort of treatment. That should be remembered. Thank you very much for giving your valuable time. Stay safe.